and I'm delighted to introduce the first of today's specialist speakers. Please do hold on to questions until the end of each session. It's my great pleasure to introduce Michael Thomson, the Professor of Health Law at Leeds University, whose research interests span the fields of health law, children's rights, and legal and political theory. Michael's work is underpinned by an exploration of the relationship between health and social justice. He's written extensively on the legal regulation of reproduction, non-therapeutic genital cutting, and conscientious objection. So, over to Michael to talk to us about reclaiming conscience in healthcare.
Thank you very much, Anthony, and thank you very much for the opening speech, which sets up what I want to do very well. And I was really delighted to be asked by Anthony to take part in this conference. I think it's an incredibly important conversation that we'll have today, and one that has growing importance, actually, and some of the things that Anthony mentioned today are increasingly pressing. What I'm going to talk to you today is drawing on some work with my colleague Sheila McGuinness, who was unable to be with us today, but I really want to acknowledge the fact that this research has been carried out by both of us. So, conscientious objection to activities that are required by law has achieved a particular place in our culture. And academics have responded enthusiastically to what's often characterised as a conflict of rights that goes to a sense of our self-worth as liberal and inclusive. Very warm, often smug idea. So lawyers, political theorists, ethicists and others have debated how we best negotiate the tensions that can exist between private beliefs and public obligations. In a significant and growing body of literature, they devise models that aim to accommodate difference and yet keep it bounded. In debating conscientious objection in this way, academics have been complicit in enabling those who wish to be exempted from the delivery of lawful, otherwise legally guaranteed services to set the agenda. Thus, our understanding has been narrowed, and conscience in healthcare has come to mean moral disquiet and how we might then accommodate the objections of individuals. My central argument is that this is an impoverished view of the place of conscience in healthcare. As claims to conscience become ever more deeply embedded in current culture wars, my argument that our task is not to debate the personal rights and freedoms of those who wish to object, but to reset the terms of the debate, reclaiming conscience as part of the moral reasoning of those who deliver services and those who seek those services. And I'm pleased to say that I seem to have caught on to what the Secular Society is doing in terms of looking at reclaiming. The conference next year is about reclaiming religious freedom. So, in order to argue for a reorientation of how we debate conscience in healthcare, so to bring it back from a place of exception, I want to address the question of abortion. Section 4 of the Abortion Act provides, with qualifications, that no person shall be under any duty, whether by contract or any statutory or other legal requirement, to participate in any treatment authorised by the Act to which he has a conscientious objection. While claims to conscience are of course seen across a range of different health services, and quite worryingly increasingly in medical education, conscience is most often associated with the delivery of abortion care. Abortion is treated differently from other health services in law, and the ability of a health provider to recuse themselves from the delivery of otherwise legally sanctioned service was historically part of and contained to this abortion exceptionalism. Yet this breaching of fundamental understandings of the duty to respond to medical needs, regardless of personal moral position, has moved from part of this exceptionalism to the conscience creep that we see in health policy and practice, and moves to extend statutory protections. So, to build my argument, I want to revisit some key moments in the development of abortion law that illustrate different understandings of conscience and help us to understand what's embedded in the current right to conscience in Section 4 of the Abortion Act 1967. And I'll be using Anthony's retrospectoscope to do this, which I will steal for further use. So first I want to revisit the case of Wrexham Bourne from 1938. And this is a pivotal moment in the development of abortion law in the UK. And the case saw the extension of lawful abortion provision and created the conditions of possibility for the 1967 Act. And this was driven by Alex Bourne's belief that he was conscientiously required to provide abortion care, unfettered by the interference of the criminal law. Secondly, I'm then going to look briefly at the passage of David Steele's Private Members Bill, and specifically the emergence of Section 4. And here we see that the right to conscientiously object emerged from those opposed to reform measures who wish to limit the impact of the legislation. And the measure was also supported by members of the profession who sought to protect clinical discretion and saw the bill as an attack on professional autonomy. Sorry, I realise the type is quite small on the screen, but I hope people can see the other screen. And third, I'm going to move on to the relatively recent case of Dugan and Woods, the Scottish midwives case that many people will be familiar with. And this is a relatively recent and very authoritative statement of conscientious objection, Section 4 and its potential reach. So these three moments help us to problematise how conscience has come to be understood and the limitations of the current debates. It talks to current very important debates around the decriminalisation of abortion and the removal of statutory clauses. But most importantly, it helps us to think differently about conscience in healthcare, and I mean healthcare more broadly beyond the example of abortion services. So, Alec Bourne was a prominent obstetrician and gynaecologist who worked in London in the early part of the 20th century. Bourne typified the establishment. He was Cambridge educated, held a number of prestigious hospital appointments, served as a military doctor, and upon his return from the war, and in conjunction with these hospital appointments, started a well-known consultancy on Harley Street. However, in 1938, Bourne found himself before the criminal court for performing a termination on a 14-year-old girl who had been gang raped by a number of soldiers. What prompted Bourne to perform this operation and strategically challenge the absolute criminal law prohibition on abortion was the view that doctors must be allowed to provide the care that they believed to be in the interests of their patients. Bourne was acquitted, and although it was not enacted until some 30 years later, the Abortion Act enshrines many of the features of the case, for example, the necessity of two doctors to validate an abortion decision. The case also has an interesting legacy in how we might understand conscientious objection. It seems from his summing up in the case that Mr. Justice Macnaghten had some sympathy with Alec Bourne's view on authority and medical discretion. He clearly respected Bourne's professional status as a man of the highest skill and distinguished his ability to perform abortions where he believes them to be necessary from cases, and I quote, performed by a person of no skill, with no medical qualifications, and where there is no pretense that it is done for the preservation of the life of the mother. Here, Macnaghten seems to endorse Bourne's view that there are areas of medical practice which are not subject to the ordinary requirements of the law. However, and importantly, Mr. Justice Macnaghten moves beyond this to comment on the extent to which medical obligation could ever be legitimately trumped by personal beliefs. He states that to provide care in circumstances as outlined in the case is not simply a matter of discretion, but one of duty, the dereliction of which could be subject to legal sanctions. So sorry, a slightly text-heavy slide for you. So Macnaghten said, there are people who, from what are said to be religious reasons, object to the operation being performed at all, in any circumstances. A person who holds such an opinion ought not to be a doctor practicing in that branch of medicine. 4. If a case arose where the life of the woman could be saved by performing the operation and the doctor refused to perform it because of some religious opinion, and the woman died, he would be in grave peril of being brought before this court on a charge of manslaughter by negligence. He would be in no better defence than would a person who, again from some religious reason, refused to call a doctor to attend his child, where a doctor could have been called in and the life of the child saved. If the father, for so-called religious reason, refused to call on a doctor, he also would be answerable to the criminal court for the death of a child. And here Macnaghten deftly refutes any understanding of professional conscience as having the capacity to overrule professional obligations. So reading Bourne's understanding of professional conscience as part of medical discretion, alongside Macnaghten's warning that personal viewpoints should be overruled by professional obligation, provides a nuanced starting point of how we might understand conscience and abortion. While clearly embedded in questions of professional jurisdiction and market control, it suggests a picture of conscience that aligns more with discourses of conscientious commitment than conscientious objection. Conscientious commitment is often reduced to the commitment to provide legally available medical services. However, Bernard Dickens describes it as, Bernard Dickens writes, conscientiously committed practitioners often need courage to act against prevailing legal, religious, and even medical orthodoxy, following the honourable medical ethic of placing patients' interests above their own. Understood in this way, the conscientiously committed practitioner is one who is not necessarily bound by law, but rather is prepared to transcend both law and personal beliefs in order to serve the interests of their patient. So, on to section 4. An examination of the parliamentary debates from the time evidence a complicated picture of the extent to which a specific statutory protection of conscience was actually believed to be necessary. David Steele had initially considered the inclusion of such a clause in his bill, but had ultimately decided, following consultation with lobbyists and medical practitioners, that this was not necessary. Against this backdrop, there are two strands of argumentation which led to the inclusion of the clause. First, it was the anti-choice parliamentarian and key opponent of the bill, Norman St John Stevens, who, during the Commons debate, required or requested the insertion of the clause. St John Stevens had made it clear from the earliest outset of the debate that he objected on principle to David Steele's private member's bill. However, accepting that statutory change was inevitable, he then tabled his request for a conscience clause, along with several other amendments which were clearly designed to restrict the reach and application of the bill. Secondly, and as I've written with Sheila McGuinness elsewhere, the medical establishment were at best reticent about the need for reform of the law on abortion. A key point of tension in the debates on the introduction of the conscience clause was the extent to which a clinician could ever be forced to provide abortion care. Here, what was being resisted by the advocates of the clause is not only patient demands, but also the encroachment by lawyers on clinical discretion and decision-making. And the long history of abortion law is this negotiation between law and medicine about who controls access to these care and services. And abortion, of course, isn't the only place where this tussle happens. In the end, it was the strongly held anti-abortion views of figures such as Norman St John Stevens that a specific provision was necessary that succeeded. However, it's clear that those who argued for the clause had very mixed motives. For some, it was an attempt to restrict the scope of the Act. For others, it was important because of the strongly held personal views of some clinicians. But for the great majority, it was a mechanism for maintaining control over abortion decision-making processes. Section 4 therefore results from an intermingling of the desire to maintain clinical control of the abortion process and broader anti-choice aims. And this is reflected in the breadth given to understandings of conscience and the freedom to exercise it. Indeed, what conscience might be is largely left without discussion or consideration. It's described in Hansard by the parliamentarians variously as, and to quote, a medical objection, a moral and scrupulous objection, a feeling, an unwillingness, or freedom of choice. And the reach of this can be illustrated in the robust and successful challenge in the House of Commons to a House of Lords amendment that proposed that a person claiming an objection had the burden of proof, so that how we would normally procedurally manage a claim to exception. Many members believed that there should be no need for anyone relying on the provision to justify or prove the nature. And here we have Gurdon saying, "Here we are concerned with the freedom of choice of the individual who has to do the work. I should have thought that it would not be necessary to have any proof of conscientious objection. Choice should be enough." And significantly, the amendment was tabled in order to avoid a situation in which a negligent physician who failed to provide appropriate care could retrospectively claim an objection to providing that appropriate care. And it's interesting to see the hierarchy of concerns that win out. So Bourne, if we go back to Alec Bourne was confident that his professional discretion had primacy over legal rules of general application. And we should be mindful at this point of Macnaughton's warning that the deference afforded to Bourne was not an endorsement of professional interests trumping public and professional obligations. Yet it's arguable that the governance of contemporary expressions of conscience do translate the deference afforded to professionals to define the boundaries of their own professional practice into the protection of conscientious beliefs. So personal authority over actions in the context of public obligations. Such conscience claims involve a call to law for protection rather than a preemption of it in the best interests of the patients. I just want to touch on this a little bit further in the recent case of Dugan and Wood. So as many people will know, this involved the case of two midwives working as labour ward coordinators. Their role involved the delegation, supervision and support of both patients and nursing staff who participated in the termination of pregnancies. Whilst both parties accepted that the role was largely administrative, the midwives had a long-standing objection to the provision of this aspect of care. Due to the closure of a local fetal medicine unit, the number of terminations for fetal anomaly happening quite late in pregnancies had increased on their ward. They sought reassurances from Greater Glasgow and Clyde Health Board that they would be able to continue to exercise their objection. The Health Board objected to the midwives' claims, stating that their activities were not proximate enough, the standard test, to the termination to qualify under Section 4. And they also importantly claimed that if the midwives were successful, it would cause a level of administrative burden as to pose a risk to patient care. And the midwives sought judicial review of this decision. The Court of First Instance held for the Trust, this was appealed, who held for the midwives, and we ended up in the Supreme Court, where, again, the Trust's decision was upheld. The case and its fallout provides an insight into the difficulties and tensions of the application of Section 4 and illustrates a further transformation in how conscience is articulated and deployed. It's clear both from the interjections of the Supreme Court justices in oral arguments and from their decisions that conscience is solely taken as an issue of religious or moral judgment. Concerns regarding deference to professional integrity had completely fallen away. So again, we've entered the end point in terms of this narrowing of what conscience means within healthcare. So Dugan and Wood illustrate many of the problems that are intrinsic to statutory protections of this sort. Not least, they require a particular identifiable group of individuals, here abortion-seeking women, to bear the burden of religious or moral convictions of another. Throughout the hearing, it was evident that the Supreme Court justices were frustrated by the lack of any attempt on the part of counsel for the trust or the midwives to take seriously the balancing of interests of the midwives against the impact on the services of having to accommodate such a wide-ranging claim to conscience. The case largely overlooked human rights arguments. A final point of discussion in the oral hearing in Dugan was the potential that the claimant's case had to impact on the 2004 regulations that require healthcare providers to refer people seeking services on to another health provider. The midwife's barrister accepted that the breadth of protection that was being claimed by the midwives could potentially impact on the requirement of referral. While unsuccessful, Dugan and Woods divided the judiciary, and it illustrates both the fragility of some provision models and the potential of the current impoverished understanding of conscience to undermine care both in the context of abortion and more broadly. I'm not sure who the chap is, but it seems sinister enough. So, the critique of Section 4 that Sheila and I are offering is not just directed at its continued presence and operation, but also recent moves to translate or transplant the provision to other areas of practice. And we've seen this, for example, in proposals before Parliament, both Westminster and in Holyrood, to legalise physician-assisted suicide. Interestingly, whilst a large body of literature exists on the problems of translation between jurisdictions, little attention is paid to this domestic equivalent. However, Ellen Stokes argues that the use of existing provisions to regulate a new area carries its own operational and ideological baggage. Any attempt at replicating provisions is problematic because the presumed application of existing measures entails more than the replication of regulatory requirements. It also involves the transmission of traditions and assumptions inbuilt in the regulatory regime. So the argument is that we need to know what's packed into Section 4 before we move it into other areas of healthcare. And partly using the retrospective scope, I've tried to look at some of the dubious and questionable motivations for Section 4 and how we are pushing this forward. So Section 4 marked a watershed in changing the legal relationship between doctor and patient. For the first time, it formally enabled a doctor to object to meeting a clinical need of a patient. David Owen, supporting the clause, nevertheless recognised this exceptionality in the context of traditional medical practice and ethics. He stated in Parliament, "It is quite wrong for any doctor to put his ethical reasons before the consideration of his patient. But I suppose this would be the only case in which we would refuse an operation on these grounds." And yet this exception has become normalised and unquestioned in many regards. Subsequent to Dugan and Woods, the Dugan and Woods decision being handed down, we see further attempts to extend the reach of Section 4 with potentially similar effects. As Anthony mentioned, Baroness Nuala Alone has introduced a private member's bill, the Conscientious Objection Medical Activities Bill, which seeks to expand the range of statutory protections for refusal to provide certain forms of medical care. Section 1 sets out 3 areas of medical practice that clinicians with a conscientious objection should not be under a duty to participate. So the first part of this slide. So it's the withdrawal of life-sustaining treatment, any activity under the Human Fertilisation and Embryology Act, and any activity under the Abortion Act 1967. As such, it broadens the range of activities that would be subject to statutory protection. Yet it's really Section 2 where it becomes apparent that this is a clear attempt to extend the scope of practices which a clinician can refuse to provide. And the wording of the bill reflects exactly the failed arguments that were put forward in the case of Dugan and Wood. So Section 2 defines participating in an activity as including supervision, delegation, planning or support of staff in respect to that activity. So this broadens the scope of the protection afforded by Section 4 and could have serious potential to impact the provision of certain sorts of care. And this is extended or heightened when we look at Section 3, the last part of the slide. And this provides that an employer A must not discriminate against or victimise an employee of A, so B, who makes use of the protections set out in this section. So there are no limitations on the protection against discrimination in any employment setting in order to facilitate the smooth running of comprehensive services. So, and we can see how that would clearly limit services in key areas. So the origin of Baroness Alone's bill are interesting. The bill has attracted support from a broad range of anti-choice politicians, and as such it's arguably an example of conscience clauses serving larger law reform goals in our culture war conflicts. It's hard not to view Alone's bill as part of the broader anti-choice agenda, and as such it's important to assess the bill not just against standards of how we protect conscientious beliefs, but also as part of the messy politics of abortion law reform. So, to conclude, it's arguable that conscience has come to mean little more than the rights of some individuals to refuse to provide care in situations where they object. Yet conscience in healthcare is, of course, much richer than this. As Shaw and Downey observe, while some may object to service provision, other practitioners feel equally conscientiously motivated to provide services such as abortion, by which patients can express their autonomy and achieve optimal health. The latter practitioners may equally feel harmed by having to compensate for colleagues' conscience-related service delays or obstruction, potentially creating unmanageable patient caseloads and or rendering care more difficult, risky, or costly. Shaw and Downey also referred to Justice Bertha Wilson's judgment in the Supreme Court of Canadian Justice that recognised that women may well have committed, considered and conscience-based reasons for requesting a termination. As Justice Wilson stated, for the state to take sides on the issue of abortion is not only to endorse, but also to enforce one conscientiously held view at the expense of another. It is to deny freedom of conscience to some, to treat them as a means to an end, to deprive them of their essential humanity. In the context of thinking about conscience differently, there's value in turning to Jonathan Montgomery's recent consideration of conscience in healthcare, where he characterises statutory provisions as anomalous, rooted in very specific settlements between society and health professions, whose legitimacy is historically contingent. Addressing conscience, Montgomery foregrounds not conflicting value systems, but good faith. For Montgomery, the conscience that defines healthcare is the conscience found in the conscientious exercise of professional responsibilities, conscientious reasoning, and conscientiously exercising of discretion. And I'll give Jonathan the final word. Thank you.